Problem.
Press the record.
Okay. I have to.
No, it's really a nice to because as just as the moderator of these 2 days, I think it's good to get a little bit in touch beforehand. The main topic you were, I think it's a very interesting topic, and there is much discussion about the topic as well, about how to close or just open a diastema. And in the Netherlands, that's a big discussion, mainly with missing laterals in the anterior region. And we tend, as dentists, there is more or less the belief that we should aim for canine guidance, so that we want to open the diastema. That's more or less how I think most of the dentists are approaching those cases. But on the contrary, orthodontists are not so much worried about canine guidance, and they tend to go for closing the diastema. Could you shortly? I mean, I know it's a difficult topic, and there are much more things that come into play whether you decide for opening or closing. But what would be your? Do you have something like an aim that you would say, okay, we'll go for opening or closing? What would be your view in that?
Erik, this is really one of the most challenging topics.
Yeah, I know.
In 30 years in the field, and I see some development. You know, when I grew up, the idea was if you have a missing tooth, just treat the case as there would be no missing teeth. Mm-hmm. And so then you have to do a bridge or an implant. So we always try to open up gaps and or open up for missing teeth and replace them with prosthetic or implantologic means. And then more realized that the primary goal should be to avoid any reconstructive interventions. This was then the new idea. And so there was a period when we closed everything and then realized, okay, this is fine, but we cannot meet all the aesthetic requirements and functional requirements if we do this. So we started to develop a little more differentiated concept, taking care of patient and of course parents' wishes, looking at the aesthetics, at the facial growth, what we can expect, the face type. Also, of course, looking, for example, if there are missing laterals, what is the shape of the canines or the small teeth? Do they have thick layers of enamel? Now we have cone beam. That's great. So we can analyze the cuspids already before they have completely erupted to plan our case, to see if it's a very big cuspid, of course, then it belongs to the place of a cuspid. If it's a small cuspid, we have a good chance to change the shape into a lateral. So then we have more options to discuss with the parents. The main problem, I think, if the patients are young, is basically they cannot do their decision themselves. So the children. So we have to discuss with the parents what they think would be the ideal solution. But still, I think whenever it is possible, it makes sense. The closure of a gap is the best solution on the long run.
Because of the longevity also of the situation. I mean, there is a lot of discussion now also going on in should we go for a bridge or an implant, and we know we tend to get more data out of the longevity of both options. And yeah, well, there is a little bit of discussion. I mean, the restorative guys, they say, oh, you go for a bridge, and the implant guys say, no, go for an implant. So it is quite, and then still you don't have the discussion at all if you maybe be able to close it with a natural tooth. I mean,
absolutely. I mean, also there are so many options because it depends why we have gaps. Also, how big are really the teeth in relationship to the arch width? So I started to work 20 years ago when I met Didier Dietschy. Actually, he was my big motivator to go more into the field of composites, direct bonding. So I realized that we can actually do a lot with direct bonding to be less invasive. and have a better potential for intervention. So he was a big motivator for me actually to try these techniques. And now I give a lot of courses for this direct bonding techniques. I think it's really a wonderful tool. To be able not to remove any tooth substance. I mean, the big problem is always that we realized more and more how modeling takes place in the whole architecture of the face. I mean, all this different bones in our heads, they change their shape over lifetime. And also the angles change in the mandibular bones and so on. So teeth actually can adapt, implants can't because they are ankylosed. And the recent years, also with the European Academy of Aesthetic Dentistry, we discussed this very intensively. For example, what can you expect? If I look at you, how would your architecture change over time? You get a wider face, a wider bone foundation, or maybe smaller, and will there be a change also in the sagittal plane? And it turned out that it's very difficult to predict. We think we know some factors, for example, orthodontic pretreatment, when we change a class 2 into a class 1, there is a higher risk than if somebody has already originally a very stable occlusion. But it's no guarantee. So what we learned is basically we need to have a concept where we can adapt over time our crowns and whatever we are using. And so the tendency clearly goes a little bit away from implantology in the anterior zone. In posterior zone, it's different. But in the anterior zone, that we look for alternatives, be it, for example, when we are using implants, smaller implants placed in a different position, just to adapt already to the changes we can expect over the next 20 to 30 years. Doing adhesive bridges, very elegant, of course, or placing a palatal implant and then using a kind of a long wire to support the pontic, just also to lengthen a little bit the period of orthodontic retention. So we don't do the final solution already with 16 years, but try to postpone it to maybe 22, 25 years. Some people even think that you should postpone it to 35 years, what I don't think is realistic.
Yeah.
Because sometimes you need to make a decision. And for me, as a conclusion, it's very important, just when we place an implant, take a smaller diameter, place it really perfectly, a little bit, not too deep and not too far buccally, so more palatal position, but then we need to take a small diameter to avoid recession of the palatal aspect and so on. So it's a very interesting thing. So actually our discussion already looks like on Saturday. That's great.
Yeah, there are so many things that come into play if you look at these factors. I mean, just one. I think a lot of participants will see this as a very interesting part of the bridges. If we have those pontic bridges, the Maryland kind of bridges, that we tend to go a lot with lithium disilicate, so monolithic lithium disilicate, because it's the bondability of the bridge is good. But we do see some fractures, and then we say, okay, let's go for zirconia. But then comes into the question, how well can we bond zirconia? I mean, we know from Matthias Kern that his book, it's all zirconia, but we tend to say, well, how is it possible that it stays in place? What's your opinion about the bondability of zirconia?
I have the same concerns. I mean, since 2-unit bridge nowadays, it's a standard. At least we do not have any more the problems we had in the past with metal frameworks when one wing was debonded and ended up with deep caries. So 2-unit is fine. And the argument always is, if it falls out, just rebond it. But it's not that simple. Rebonding is not always so easy.
Oh.
Certainly, I think there is a good protocol how we can treat the surface, which we will discuss. However, I don't think the quality is equal to the quality we achieve with lithium disilicate. I agree completely with you. So we need to pay a lot of attention to the design of the connector and the occlusion when we are using lithium disilicate. And I always use, I would say, 90% lithium disilicate and 10% zirconia, only if we had not enough space, intermaxillary space, but a big area. So with, as a short conclusion, with lithium disilicate, the problem is not the bonding, the problem is the connector and the occlusion. With zirconia, the problem is less the connector, it's more the bonding area. So we need to construct bigger wings.
Yeah, very interesting. I like that concept a lot. I mean, that would make things easier to decide whether to go for a lithium disilicate or for zirconia. I really like that. I think that's something what people really need to understand. I mean, there is room for both.
Absolutely, absolutely. And I mean, the question then is, maybe introduce some kind of retentive elements, grooves, proximal grooves, or chamfers at the cervical region. And my idea was always, when we have a non-invasive concept available, we should avoid any preparation, aside of maybe rounding a little bit internal angles and so on, but that we do not need anymore to remove substantially tooth substance, so that we do not do any more grooves and whatever. And the problem always was initially, people believed that zirconia behaves like a metal, so you make the same kind of micro preparation we were using for metal. And then we thought, okay, this is not logic because it's too invasive, even with this. So let's use lithium disilicate because the bond strength, there is no question. It's the problem more is how do we position the bridge during the cementation procedure? Yep. What can we use to be sure that our position is correct? And of course, when we prepare a little bit, this makes our task easier. However, if I